Thank you, and welcome for joining us today. My name is Jennifer Schaefer, and I will be your WebEx technical support host. Before we dive into today's webinar, I wanted to provide some quick information on the webinar platform. All lines have been muted on entry and will remain muted for the duration of the webinar. Please submit your questions throughout the presentation using the chat or Q&A panel, and a moderator will ask those on your behalf. If you require technical assistance, please contact me, the host, via the chat or Q&A panel, and I'll be happy to take your questions. If you need live closed captioning, please refer to the link that will appear momentarily in the chat panel. I also would like to note that today's webinar is being recorded and will be available online within the next 1 to 2 weeks. And now I'd like to turn it over to Emily Tonorozos to introduce today's webinar and our speaker.
Thank you, Jennifer, and thank you everyone for joining us today. It is my great pleasure to introduce Dr. Shauna Hudson as our inaugural speaker for the NCI OCS 25th Anniversary Director Series. Dr. Hudson is a Henry Rutgers Chair and Professor of Family Medicine and Community Health at the Rutgers Robert Wood Johnson Medical School, where she also serves as Research Division Chief. She is a full research member of the Rutgers Cancer Institute of New Jersey and the Cancer Prevention and Control Program. She has a secondary faculty appointment in the Rutgers School of Public Health in the Department of Health Education and Behavioral Science. She currently serves as Director for the Community Engagement Corps of the New Jersey Alliance for Clinical and Translational Science, a Clinical and Translational Science Awards CTSA consortium of Rutgers University, Princeton University, and the New Jersey Institute of Technology. As you all know, Dr. Hudson has published extensively and is internationally known for her research that examines long-term follow-up care for cancer survivors and their transitions from specialist to primary care. She is a medical sociologist and a community-engaged primary care researcher working with vulnerable populations at the intersections of community health, primary care, and specialty care. Dr. Hudson's research has been featured in a number of journals, including Annals of Family Medicine, Medical Care, Lancet Oncology, JAMA Internal Medicine, Journal of Cancer Survivorship, and the Journal of the American Board of Family Medicine. She has led and participated in a number of research studies funded by the National Cancer Institute, the National Institute on Minority Health and Health Disparities, the Centers for Medicare and Medicaid Services, and the Robert Wood Johnson Foundation. She has served on numerous editorial boards, review panels, and advisory committees, including the NIH Dissemination and Implementation Research in Health DIRH study section. She is a gubernatorial appointed member of the New Jersey Commission on Cancer Research and a member of the editorial board for the Journal of Cancer Survivorship. Most recently, she served as a member of the National Academies of Sciences, Engineering, and Medicine's Committee on Implementing High Quality Primary Care, a report which we all read with great interest. It is truly my pleasure to introduce Dr. Hudson, and I'm so glad that she can join us for our inaugural talk today. Thank you, Shauna. Welcome. Shauna, you're muted. I'm sorry.
There you go. Oh, I heard something. Did someone unmute me? I believe I'm unmuted now. Lovely.
Yes, you're good to go.
Excellent, thank you. So I wanted to thank you for that really warm welcome, and just to say that it's a pleasure to be here with you all today, giving this inaugural speech for the Office of Cancer Survivorship. I want to take this opportunity to acknowledge all of the great strides that have been made possible through this office, beginning with the work of Julia Rowland, who inspired me to pursue and continue this line of work in primary care research. And I'm really looking forward to another 25 years with Emily at the head of the office, moving forward that agenda and taking a look at the growth of the portfolio. So what I want to do here is to congratulate everyone for the 25 years of support and to point out here at the bottom left-hand slide just how much we've seen in terms of growth for numbers of grants as well as the dollars in grants that have been provided for cancer survivorship research. One of the things that's always interesting about a portfolio look back, and Dr. Rowland did a really nice job of this, looking at the portfolio in 2016, is to see how the money actually is expended in a given year. And so if we take a look at the grants in the portfolio from 2016, you'll see that the vast majority of grants are actually around looking at physiological issues, health issues, and then as well some psychosocial issues. There's very little work in the portfolio, at least at that point in 2016, that was focused around issues of patterns of care or care quality, looking at sort of the context around which cancer survivors and patients and then healthcare clinicians are actually providing care. And so it's really in that space that I'm going to be talking to you today about the work that we've been doing in primary care. So I want to start off with a quote from a paper that Sally Weaver and Paul Jacobson did as a commentary in Translational Behavioral Medicine that really sort of sets the stage for why we're looking at primary care as a partner in survivorship and in moving forward the agenda for better patient care. So in their paper, they talk about the involvement of primary care providers is now regarded as a central issue in survivorship care, given the growing demand for acute cancer treatment services that is taxing our existing resources, the rising prevalence of comorbid conditions among cancer survivors, and the increased emphasis on value in U.S. medical care reimbursement policies. And they go on to note that there is much work preliminary work that needs to be done in this space. And so it's within the context of thinking about patients nested within systems of care and then nested within their local, state, and national context that I'm going to be talking to you today about what we've been finding in our research and what we've been seeing in terms of sort of the challenges for primary care, but also the opportunities that I think that we have to really address the needs of primary care as we think about how do we deal with this large growing population. So I want to actually start off by introducing you to my primary care research team. I'm very fortunate to work with a number of individuals here at Rutgers University who are really devoted to this work and bring very interesting and different complementary perspectives on survivorship and then also on primary care. So many of the names you'll actually recognize from our publications. In the back row in the hat is Dr. Ben Crabtree, who's a medical anthropologist and a long-term collaborator of mine who has really been focused on organizational change. You'll see Stacy Davis, who had a diversity supplement with us on my R01 for Excels, and as well our department chair, Al Talia, and Jennifer Himmler, who's done a lot of work in our survivorship studies. In the middle, you'll see Dina O'Malley, who currently has a K99 ROO from NCI in cancer prevention and care and also implementation science, as well Jennifer Sway, who's just moved to USC, who's doing work in HPV. Sitting in the front is Jeannie Ferrante, who's a family physician, and so her insights are invaluable as we think about sort of what can be done within the clinical setting and how do we move forward. And as well, Pam Oman-Strickland is our biostatistician. Alice Bader works very closely with her, and Jenna Howard is our qualitative analyst who's been with our team for many, many years. So I wanted to make sure that I put the context of sort of who is behind the work that we're doing so that you can see sort of how our perspectives actually inform the work. And I think, as Emily mentioned before, I'm a sociologist. So again, having social scientists and clinicians at the table who are all thinking about these projects and problems from multiple levels, thinking about the patient, the healthcare team, and then the practice in which we're situated is really important to actually thinking about how do we move implementation in ways that will help us to achieve what we want for our patients. So I want to start off by just sort of putting into context the population of survivors that we work with. So the population of survivors that our group is focused on are those who are in long-term, So they are at least 2 years out. In the case of this study, which we've cited many, many times from 2009, the vast majority of cancer survivors are actually are living longer and longer and further years out from their cancer survivorship. And so one of the things that was interesting to me as I started to think about this as a question for my Career Development Award back in 2008 was really looking at sort of where are survivors actually receiving their care, given that survivorship care plans were not available for many people, and for many people who have actually finished their active treatment, they're very limited in terms of their dissemination widely. Really looking at what are the issues and what are the supports that they have within primary care settings. And so some things that were really interesting and important take homes for us and our team were that 1/3 of our long-term survivors are continuing to seek care in cancer settings, but that means that 2/3 of them are actually in primary care or somewhere else. And then the other piece that was important is thinking about the population of survivors with localized disease. And again, we are not looking to take the place of oncology. We want to work together, and one of the major models is really shared care and thinking about how do we do shared care in meaningful ways. And so for patients who have had localized disease, again, our questions were, where are they most likely to be seeking care, and where are we most likely to see them? And in this study that was done in 2009, we see that very clearly, the further you are out from an active cancer diagnosis, the more likely you are to be seen in primary care. I should also say that the populations that we work with in terms of our studies are really adult onset cancers. So I'm going to be limiting my comments today to the literature in that area, and so not really focusing in on childhood cancer. However, I think there are similar issues in terms of navigation and thinking about transitions of care that we can talk about during the discussion around that. So with that as a caveat, I want to talk to you at the beginning of this talk. I've sort of segmented it into 3 different phases. So I'm going to talk to you about what we found in our studies of patients. I'm going to move into some of the work that we've done here that's been funded by NCI around healthcare teams and clinicians. And then I'm going to finish up with a study that we just had funded in July that's really looking at practice organization and practice settings and change. So the next series of slides that I'm going to share with you really come out of my initial career development work in the Life After Cancer study, which was a qualitative depth interview study of 42 breast and prostate cancer survivors. Our goal was to understand what were experiences that survivors had within our NCI designated cancer centers, and to compare them with the experiences of people who are seeking care in community oncology settings. And then I'm going to talk to you about the second phase of my K01, which was also funded by an R03, which is a survey study. So we really used that qualitative data from the first study to inform the development of a survey to better understand more broadly how were the things that we were finding qualitatively translating into the experiences of a broader group within the survey. And then both of those studies provided formative data for our R01, which was funded back in 2013 and just recently finished up of primary care intervention that we developed within for patients within primary care. So that sort of sets the stage for the studies that I'm going to be talking about and some of the findings that I want to focus in on. So one of the first papers that came out of the K Award was, in the qualitative work that we did, was this paper, which was focused around adult cancer survivors discussing their follow-up care and primary care. And the seminal quote from that study was really, "Not what I want, but maybe what I need." And it was interesting to us because as we spoke to survivors, we found that the majority of them had some concerns about seeing their primary care providers, but that they were open to a shared care model. They just didn't see it in their everyday experiences and didn't know what it would look like. And so when we talked with them, they we often heard stories about them saying that they should be seeing their doctors who are oncologists because that's what they deal with all the time. When they think about follow-up care, their context was really that it needs to be done within an oncology setting. And the second quote here on the slide, I love my family doctor, but he's a board certified internist. And I guess that's the correct term. He's a great doctor, but I don't know how to quite phrase this. If I owned a Ferrari, I wouldn't take it to a local mechanic to have it fixed. And so sort of the context around thinking about wanting the best specialty care that you can possibly get for your car or for your body in this case, really patients and survivors didn't have a good sense of what survivorship follow-up care was. And so we're really sort of thinking about their treatment context as the context for the next phase of their care, which is follow-up. So the next thing that I want to sort of focus on from this study is perhaps probably the most important piece, which is there was an Institute of Medicine report that came out, many of you on the call know about it, and in 2008, that talked about sort of the major pillars of what is follow-up care. And so it was sort of dissected into 3 areas: cancer surveillance, meaning that you're looking for recurrence for your cancer. There was also looking for cancer screening for new primaries, and so that fits in within that context. There's treatment effects, so looking at the effects from either the chemo or surgery or other types of treatments that individuals have had. And then finally, care coordination. So figuring out which docs, when, how to actually put all these different things together. If you're a breast cancer survivor and you've had chemo, there may be some need for cardiology follow-up and other things. And so thinking really about sort of the care coordination. And what we found in our study that was really telling is, and sort of explains the comments that we got on the first slide, is that individuals, when we asked them what is cancer follow-up care, for the most part, they said that it was just about looking for your cancer coming back. It wasn't about preventive screening. It was very little to do with treatment effects and very, very little to do with care coordination. So when you think about the context of how follow-up care is actually done, what are the things that we're doing in follow-up care, a lot of it is care coordination in dealing with side effects in treatment, and that's not to minimize the surveillance piece. But patients really don't sort of think about that as the first thing that comes to mind for them. So we're sort of swimming uphill when we're talking about processes, and the people that we're talking to about it are really thinking about sort of a one-stop shop for an individual test. So that was one thing that was sort of revealing in the first phase of studies. The other piece that was revealing to us is we really were interested in this concept of self-management, which is throughout the cancer survivorship literature. It's also really tied into what was called the patient-centered medical home at the time that we were doing the study. And it really sort of brings to mind that you need to have an activated patient, someone who's willing to be able to be the bridge between their cancer treatment teams and their primary care teams, and then the other specialists that they may have to see because of late and long-term effects, that you have a patient who's actually doing a lot of the coordination. And so one of the questions that we had for our patients in both the community settings as well as in our NCI designated settings was really how prepared are patients for self-management of their follow-up. And what we found in that study is that there were basically 3 different types. And the 3 types that we had were individuals here in the top left who had very little understanding of what follow-up care was and very limited or low activation. And so they tended to be in our community settings that were mostly urban, tended to be lower SES, also tended to be patients of color, and had very little resources, both within their communities and then also within their cancer center settings to be able to better understand what follow-up care was. Then there was a middle group that were highly activated patients, but also had very little understanding of follow-up care. And we found them mostly in our community oncology settings. They tended to be more suburban, had higher SES, were less people of color, and were sort of in the middle in terms of where they were on the spectrum, because they were able to get themselves to settings where they felt like they were getting great care for their treatment, and therefore it would translate into their long-term survivorship care. And then the third group really were the folks that we were seeing in our NCI designated centers. And so our study took place at Fox Chase and as well the Rutgers Cancer Institute of New Jersey. And what we found there tended to be people with much higher SES, more resources, the centers themselves had more resources, and the teams were already sort of multidisciplinary teams, so that they had already been sort of exposed to the idea of possibly having team-based care and we're used to that. And so then we're also more highly activated. And so it was interesting in the context of this particular study to think about these different types of activation and where patients are in this sort of trajectory. And then how do we actually translate that into resources for patients to move through the system. Another thing that we were really interested in is what are the relationships that patients have with primary care? And so in our survey study, we really wanted to do a deeper dive into the components of what is called, patient-centered care. So is it comprehensive? Is it coordinated? And what's that personal relationship look like with providers over time? And what we found in our survey study is that when we looked at breast and prostate cancer survivors, that there were significant differences in terms of the types of experiences that they had with care, and also who they had affinity for. So you'll actually see that for both the breast and the prostate cancer survivors, if you look at the comprehensive and the coordination of care items here to the left of the graphic, that for the most part, they were very comfortable with their primary care and they favored their primary care. So those are all of the bars above the line at the bottom. If you take a look at personal relationships over time, the breast cancer survivors actually said that they had much stronger relationships with their oncology team and their cancer teams than the prostate cancer survivors did. And we found that to be really interesting because I think it speaks to sort of how do we think through who is going to be most comfortable, when do we need to start having conversations about care transitions, and what kinds of conversations do we need to have. Also, we think that there are some interesting differences in terms of age and exposure to primary care. So we know that breast cancer survivors tend to be a bit younger than prostate cancer survivors in general. And so are interested in sort of seeing how do those relationships and those experiences of care actually translate into experiences with long-term survivorship. So we sort of moved from those initial sort of studies around understanding what do we do with patients, how do they think about these issues, and what are sort of the mental models that are constraining their thoughts around primary care. And we wanted to move into an intervention that was really focused around enhancing self-management. Because we, frankly, as a sociologist, I was sitting there looking at the system going, there's limited things that I can do as an individual to address the systemic issues of care. However, there are things that we can do for patients to help them leverage the systems. And so perhaps if we were able to give them tools, then we might be able to see some changes. And so the R01 that we started and just recently completed had two components to it. One was an mHealth component, which was a mobile optimized website. And then the second component was a health coaching piece. And it was based theoretically on the cognitive social information processing model that my colleague Suzanne Miller at Fox Chase has really sort of moved forward throughout the literature. So one of the things that we found in terms of looking at what was it that patients wanted, it sort of reconfirmed for us our qualitative work at the beginning, which was all of our breast, prostate, and colorectal cancer survivors, they all wanted information to help them learn and prepare for their meetings with their primary care around follow-up. So all of them had educational concerns, and it's not surprising because, again, survivorship care plans, this was a longer term sort of group that were not exposed to survivorship care plans. So they didn't have that information. They also wanted to have their questions addressed. And many of them talked about sort of going to the doctor and then coming home and then realizing that they had forgotten something that they wanted to talk about, but they weren't able to sort of bring it back. And so wanting there to be like a question bank that they could customize for their needs, and also understanding that their needs, some of them are going to be, unique, but for the most part are likely to be patterned questions and responses that others have had. So wanting to know sort of, based on a profile of a person like me, what are some of the issues that I should be looking for, and what should I then be talking to my doctor about? They also wanted a way to organize the information, just some general information on how to stay healthy. And then also there were sort of, it was a bivariate distribution in terms of how much emotional support do you want from a particular piece here. So there were some people who wanted a lot and thought that perhaps this might not be what they needed, but thought that the health coaching would be great. And then others who liked this idea. And so that's part of what we're testing with and finishing up our final results on the study. So what we found were that people actually liked both the interventions. We found that people who did both the website as well as the health coaching seemed to be more engaged than doing one or the other. And possibly it's sort of getting used to the information and being able to see it over time. But we were really sort of intrigued by the findings here and thought this is great. And then we started to hit a wall when people were saying, well, okay, now I have this resource. Where do you recommend that I go to talk to primary care? Because when I talk to my doctors about this, they're not as excited about it and they don't really know what I'm talking about. So just a quick summary of sort of the main, I think, takeaways from this patient data that we collected is that patients who have a history of adult onset cancers don't really have a clear sense of what cancer follow-up is. And their skills and knowledge base for self-management is highly variable. Something that I didn't mention, but that's important, I think, here is that, the salience of follow-up actually seems to wane over time in terms of the length of time from diagnosis. So for our survivors who were further out, we saw less uptake and continuing of the intervention than people who were very early on, maybe 2 years or less out of their diagnosis. And so we know that their education needs vary over time and that their relationships matter. The major barriers to primary care that we heard from them were real concerns about lack of communication with the oncologists, the concerns about coordination and referrals, and then also the need for there to be some sort of specialty training around what cancer follow-up care is and monitoring. And again, sort of not understanding what is the definition and where did those sorts of things happen on a regular basis. So at about the time that we were in the field with Excels, my colleague Ben Crabtree had been doing 2 different projects. One was an ARC-funded dissemination conference program where he convened an expert panel on innovative primary care. And we were able to do a series of interviews with some exemplars across the country who talked with us about their issues and concerns with providing the care. And then that data, as well as some of the patient data that we had been gathering provided preliminary studies for descriptive R01 looking at cancer survivorship within the context of a patient-centered medical home. And so we were able to take a look at a deep dive into 14 exemplar primary care practices. They ranged in terms of size, in terms of geography, and also their engagement with cancer survivorship. And so I'm going to talk to you a little bit now about what the findings were from that study, or from those two projects. So from the R13, one of the things that was really important, and not surprising, I'm sure, to this audience, is that within primary care, there is a lack of financial incentive for survivorship care. And so we heard from the panelists who were in that meeting that those of us who continue to care for the patients are actually financially penalized for doing so. It disincentivizes primary care to pay for patients in their own practices. They talked about the productivity pay structure rewards doctors for doing high volume care, not necessarily high quality care. And in particular, they also talked about the issues with complex and changing healthcare issues in survivorship, that it's always going to be low volume care. So without there being some policy changes or changes in terms of payment and other structures that in the current setting, within the context of their practice, that while it was important to them and it was something that they were all very that they were all championing and moving forward within their settings, it was something that they were doing on their backs as opposed to something that was actually supported by systems of care. I'm getting a signal, so I'm going to move that. Going forward. So in terms of the R01 study, we found also that there were a number of things that the exemplar practices across the country sort of added to the discussion around survivorship. So I think they actually put a more finer point on the issue that came up in terms of incentives and payment structure from the R13 participants. They talked about cancer survivors not being a distinct population within primary care. And so this second quote, I think, is really exemplifies sort of what some of our primary care colleagues were thinking, which is, I don't think of these patients as survivors. I think of them as people living with a history that's not terribly unlike the history of diabetes or any other chronic disease. So, so not really sort of calling out there's a population that we need to look for. They also talked about electronic medical systems being insufficient to support survivorship care, so that really our EHR systems were not user-friendly. It requires searching multiple screens to be able to find any mention of cancer, and then really lamenting sort of the olden days, which are not coming back anytime soon. But I think that there are some things that we can do to make our current electronic medical records much more easier to be able to find this population. One of the things that we found in the Excel study, for example, is that even though you have history of cancer listed, there was not necessarily an ICD-9 code at the time that we did that study. And so there was a Z-score that we could look for and that the practices were looking for. But again, it's a lot of work for clinicians who are busy in practice to add an additional layer to be able to try to figure out who those folks are and then how to make sure that you're getting the right care to them at the right time. We also found that the clinicians talked about having limited information on follow-up care and guidance. And so most of the practices that we talked to had not really seen a cancer survivorship care plan or a care summary. And then they really wanted to understand what the treatments were, but it was kind of a black box. So they felt very intimidated by trying to understand sort of what the needs were. The other thing that we found was that while there were these concerns and these issues, when we talked with providers and with primary care, they also said that, you know, cancer survivorship, because they're not a distinct population, they are folks who are in our practices that we need to serve. And there are tools within our practices that we've been utilizing for chronic disease management, such as care coordinators and also registries and other items, that there are already tools that exist, but we've really just not maximized them for usage within primary care settings. And so while they pointed to a lot of challenges, they also pointed to opportunities, I think, for us to really start to move forward in terms of leveraging things that already exist within the existing system. So there's some care coordination food for thought here, because there's a nice review that was done in 2017 that looked at sort of the relationship between primary care and cancer specialists, and really sort of laid out all the arguments that I've just talked about. So we know there's poor and delayed communication between primary care doctors and cancer specialists. And we also know that the cancer specialists in general tend to endorse their specialist model of care. We do know that primary care clinicians believe that they have an important role to play in the cancer continuum, and they're willing to perform the role, but they need to have the tools to actually help them do that. And so there's sort of this interesting discord between the cancer specialists and primary care specialists around what are the expectations and the roles, and how do we engage with each other around them. So I had the opportunity to work with the American Cancer Society and ASCO on a series of looking at risk-based care and thinking about populations for whom there's fairly low risk for their cancers to come back, and to think about what are the ways in which we can think through research questions that would be really important for us to address, to help to think about the ways in which we can help facilitate some shared care models, and also to think about how primary care can work together with oncology to address the needs of our survivors. And so out of the 10, I think, research questions that bubbled up to the top in a Delphi study of experts in the field, 4 of them I think are really relevant to this issue of primary care. So the first one is, we need to really learn what types of system and policy changes can help to incentivize our health systems to shift care for low-risk patients to primary care or other specialty clinics. We need to think about what types of changes might incentivize our oncologists to shift their care for low-risk patients to follow-up care clinicians who are outside of the original teams. We need to be thinking about what policies, practices, and infrastructures are needed to facilitate self-management. And then also, again, these are research questions for which we have lots of questions, but very little data at this point. How should our follow-up care clinicians be engaged and aware of cancer care to help facilitate the provision of follow-up care at health systems and practice levels? So thinking beyond sort of the walls of the clinic, but also thinking about in the context of other settings. So with that, I wanted to round out my talk and make sure that we have time for questions, to talk a little bit about a project that we're doing now, where we finally sort of, I think, figured out that we can't sort of do all of this in absentia of each other, and that there needs to be some overlapping of the questions and of the methods. And so in our current study that was just funded in July, we're actually doing a practice-based intervention, or we will be doing a practice-based intervention that's looking at patients nested within clinicians and healthcare teams and practice organization settings. So our study is a hybrid one that's focused on evidence-based interventions for breast cancer follow-up in primary care. We actually decided to focus in on breast cancer because it's one of the areas for which there's a really mature I think, evidence base for the interventions and for the strategies that have been suggested. And one of the things that we found that was that we thought was interesting and important about the study is that we wanted to do 3 things. the first aim, or the first thing that we wanted to do, is to really engage a diverse set of primary care practice stakeholders in identifying what's actually actionable for the practice-based activities that are in our guidelines. And we're doing that using depth interviews in our first aim. And the second aim, then, we're looking at prioritizing and synthesizing what those activities are. And we're using both a Delphi method and panel and a concept mapping strategy to do that. And I'll talk a little bit about that in detail in the next couple of slides. And then once we figured out sort of what is it that there is that's possible to do, what is it that our stakeholders say is what they want to do, then what can we actually implement? And can we evaluate in what settings are different types of strategies going to be best facilitated in terms of implementation? And so that's where our hybrid type 1 effectiveness study design comes in. So we're going to be working with 26 primary care practices in our Robert Wood Johnson Barnabas system here in New Jersey, 13 of which are going to get the intervention, and then 13 of which will get a waitlisted control. So what we started with this study is, and many of you know this, there are a number of different guidelines that exist, and ACS and ASCO have done a really nice job of pulling together the evidence and then putting together guidelines for primary care that are focused around breast cancer, prostate, colorectal, and head and neck cancer. I think one of the major problems, and one of the things that we identified in the science as we were looking at this particular project, is that these guidelines, though well-meaning, they've been top down. They've come from oncology, and there have been folks who have been engaged in the process, but very few sort of on the ground primary care, other folks who are engaged in the process are part of these guidelines. And so what we wanted to do with this study is to really take what I've actually learned in the sort of the CTSA community engagement space, is to think about it from a stakeholder engaged perspective, where our goal is, we didn't quite make it to the top of the team because Ben and I are both social scientists, so we're not actually clinicians, but we've got to the second tier there, where we have a research team that is very diverse, that's comprised of all of the different stakeholders, and the team, as well as the different folks that we're looking to recruit for the aims, is really focused around making sure that there's reciprocity and sort of a ground up swell to thinking about the study. So I know this is a busy slide, but part of what I wanted to show in the busyness is the number of different groups and folks that we have around the table. So we have our primary care colleagues at Lehigh Health Network, at UT Southwestern as consultants. We have our oncology, and actually Kevin Effinger is working with us at the Duke Cancer Center. We've got nursing involved with Deb Mayer at the UNC Linnenberger Cancer Center. We're working with Catherine Alfano at Northwell Health. And then as well, we have two survivorship groups, Survivor Journeys, which is Jay Burton, and then Sister to Sister, which is an African-American breast cancer survivors group that's locally here in New Jersey. They're all part of our research team, and they're all in part of our process around the science for this. And then we also have an assist from Jeff Curran, who's a consultant on the study for our hybrid design for the implementation study. But also on our qualitative teams, on our Delphi team, and on the intervention team, we have a clinician researcher, Jeannie Ferrante, who I mentioned before. We have an oncologist, Deb Topmeyer, who is working with us locally. And then as well, we have other clinicians who are involved, and individuals from a social science perspective who are really sort of thinking through the science pieces on it. So we really wanted to model in the study design team what we wanted to see coming out of our different aims. And our implementation model is one that uses two theoretical frameworks to think through practice. So the first one is a practice change model that Ben actually has been moving forward with Deb Cohen and other colleagues to think about, within the context of a practice, what are the resources for change and the opportunities for change, as well as the motivations that impact us from both the external and the internal context. So there's sort of the practice change model that we're thinking about from the perspective of how do you implement. And then the other piece of this is really thinking about implementation science. So, okay, we go through this first phase where we do the needs assessment and we do depth interviews with different key stakeholders. Now we actually bring in the second aim, the Delphi and the concept mapping with practitioners in the field who are actually doing the work and saying, okay, well, in theory, these are what our primary care, our oncology, our policy stakeholders, our researcher stakeholders think is doable. What do you think is doable here? And then we're going to spend our time implementing and then figuring out if we can sustain the implementation through this hybrid study in AIM 3 with the 26 practices. And what we're going to be focusing in on is the implementation. So is it appropriate, acceptable? How is it adopted in different settings and what's feasible? And we're going to be looking at, as our clinical outcome, how is breast cancer follow-up actually going to be addressed? And so this last slide here for the study just gives you a sense of what the guidelines show for primary care for breast. So we synthesized the guidelines and sort of turned it into a list of about 23 items that clinicians are supposed to do to either assess or treat or counsel or provide a referral. And so what we're going to be working with all of these stakeholders on is to better understand, okay, of the things that we can actually measure in an electronic medical record, which of these things are doable? How will you get them done? And what will that look like in different contexts? So with that, I want to just end where I started, which is coming back to sort of primary care. I think what we're really striving for here is shared care and survivorship with oncology. And so I want to go back to the quote from the Weaver and Jacobson article, because I think really the critical background work for us now is to define the provider behaviors that reflect shared care of cancer survivors, specifies the processes and mechanisms that our oncologists and our primary care providers should use to facilitate that care, identify different cognitive states and shared goals, and also identify interpersonal factors that are facilitative of effective sharing of care. So with that, I want to just acknowledge my global team. I know you can't see everybody, but I know the slides will also be available. I think that it's really important to work in different teams and to think about wicked problems. And so this is one of my favorite quotes about effectively addressing and understanding wicked problems requires a combined knowledge, skills, and innovative capacity of a wide array of disciplines. And then I want to acknowledge our local team again, and as well NCI for their support of this work. So with that, just want to say thank you, and I am happy to turn it over for questions.
Thank you, Shauna. That was amazing. And I know we already have some questions in the chat, and Nicole Science is going to help us get through those. But I just wanted to say, it seems to me, listening about this work, that you've had a little bit of an evolution where when you were talking about Excels, you said you were targeting the system by intervening at the individual.
Yes.
And it was really about the activated patient as a goal in that work. And now you're really doing something quite different. So could you just reflect on how you shifted?
Yeah, it was interesting because I really came at it from a perspective in sort of the psychology training that I had as part of my K was, okay, we're going to work with individuals and we're going to make sure that the individuals are fortified with as much resources as we possibly can. And then what I found is I ended up going back to sort of the context of care. And it's not that it's insurmountable, but I think we need to have a system of care where patients can actually bring in those resources and talk about it. And what we found with Excels is that, first of all, our primary care practices really couldn't identify the cancer survivors because they were going back to their billing systems and doing all kinds of things within the academic medical center that our community practices didn't have access to. So that was the first piece of it. We also ended up having to change our recruitment strategy for that study because we couldn't recruit in primary care. So we ended up going to a cancer registry. So part of what we ended up doing, that evolution, was really just looking at, you have to take the system where it is in context, and where the system was in context for us at that point was it was not quite ready for, it wasn't a receptor site. And so that's how we sort of moved into the descriptive work around the exemplar practices, because we said, well, these are everyday struggling practices. So maybe if we look at practices that have lots of resources, have they figured out the magic bullet? And what we found with the exemplars is they too were struggling. So it means that we kind of have to think more systematically about systems and context rather than trying to fix, I say in quotes, the patients and have the patients try to navigate, because we as clinicians can't even navigate the system. So why would we expect that patients would do that?
Thank you very much, Dr. Hudson. So as Dr. Tenenrezos mentioned, we do have some questions for you already, and comments as well. First, this is from earlier in the talk. Given these differences between breast and colorectal cancer, do you believe that it is about age or about gender or something else? Very intriguing.
So I think it's a combination. I think it was the breast and the prostate cancer patients earlier on. It is, I think, about age. They have longer relationships, the prostate cancer survivors, with their primary care. But I think there are also some gender things. There's also the experience of breast cancer is very different than the experience of prostate cancer. So there's sort of a longer timeline depending on the type of treatment that you get for breast cancer. And so you may be with your treatment team for a year, which would explain sort of that relationship piece, in ways that with prostate cancer, it could be 6 weeks, or, it's a much shorter period of time. So I think all of those things are interesting, and they're hypotheses that we have, but we haven't tested them.
Thank you. And the next question, one-time care plan is unlikely to address concerns and questions several years into the future. And I've never yet had a primary care provider or survivor tell me that they used a survivorship care plan to answer a question. That was one comment. The next comment, this observation about the problem list is also tied to reimbursement, as potentially the inclusion of the ICD-10 code for the cancer follow-up would justify billing for a higher level visit. So this could be important to address.
Yeah, no, we think that that's really important. And so we're hoping that that sort of policy change in the context may actually make the work that we're doing with the current project a little bit easier, because again, we didn't have that in the context of Excels. And so now I think we're moving into a different context.
The next question, what is the future of training for primary care doctors? Would a fellowship be needed?
So that's a really good question about the future of training. It's been interesting because I've been on the National Academy's implementing high quality primary care committee for the last year. And so one of the major recommendations that we have, it's not focused on cancer survivorship, but is really around sort of whole person centered health and training. And so I think that there are opportunities to think about how we retrain. Frankly, the systems are not quite set up at this point to address them. So I think it's more of something that we need to explore. certainly an area that needs more research and that we need more people engaged in that area.
Thank you. The next question. Terrific trajectory over the course of your work. Could you speak please to priorities you see for studying disparity populations in survivorship care delivery?
Yeah, so, one of the things that I think is really important is being able to look at different contexts. And so we have collaborators who are at UT Southwestern at Parkland who are doing work in survivorship, and being able to look at what happens within, say, a federally qualified healthcare center versus a regular primary care setting versus an academic primary care setting. Those are some of the things that we actually have some real questions about in terms of thinking about sharing care, where there are already systems in place that could be leveraged, and then where there are places where we need to build new systems. So I think that, there's sort of that organizational look at it, but then I think there's also room for studies that are focused around patients and community populations, looking at engagement and thinking about the ways in which we do our recruitment and other things that we could also be involved with. So I tend to think more in terms of sort of structure and process, but I think that there's room at the end for all of this work to happen across the continuum, because we really do need to move our disparities work. And a lot of it has still been, it's important to see sort of what are the secular trends in terms of data, but I think we really need to move into interventions. And so thinking about where do we actually intervene and at what levels, and when do we need to do multiple levels of intervention is going to be really important to address disparities.
Thank you. And the next question along those lines. Thank you for a wonderful presentation, Dr. Hudson. Any thoughts or suggestions about the types of tools available or needed to implement evidence-based survivorship care plans into primary care settings?
Yeah, so it was interesting when we wrote the grant for this project. There's an app that has the guidelines that the American Cancer Society developed. I'm hoping that it's updated for the iOS platform. And so I'm going to be working to see if we can't do that. But there's also the work by GW. And so there's a lot of training that's already out there around the guidelines. And so really one of the things that we're planning to do, at least in breast, and again, that's one of the reasons we chose breast cancer, is that there were a number of different activities and things that already exist, patient support materials that were already developed that we could use that were already developed around the guidelines. So I think that probably the evidence base is a little less mature for some of the other settings, but that there are resources that are out there with different groups.
Thank you. The next question, what are the most important takeaways from the cancer and chronic disease parallels in implementing primary care practice change?
Yeah, so it's interesting because I think there are the tools that exist. So the idea of doing a registry is not something that's rocket science. It's just something that we don't actually have the resources for currently. So there's sort of that piece of it, being able to identify the population. We know that we've had navigators that are working with different patient populations, that's been used quite well. The health coaching has been used quite well for chronic disease management and diabetes and other areas. So I think there's a lot that we can learn from things that already exist. It's really a question about sort of how does that implementation need to be adapted around the context of cancer survivorship.
We have a couple more questions. Great work. Your work shows some uncertainty in the relationship transfer between providers, and I think patients sense that. Is anyone doing research on that particular transition point?
It's a really good question, and I would have to say that I've not seen it, but that doesn't mean that it's not being done. I think it's a really important area, though. I would love to see that develop more.
Thank you. The next question, what would you say has been the greatest area of progress made in the PCP survivorship space since the original IOM report?
So I think that there are multiple models of care. So being able to see that there are a variety of different ways of providing the care, I think has been helpful. One of the things that I think would be interesting is the testing of the implementation. So we haven't quite gotten to the what really works and what really works well. So I think there's been an advance in the literature in terms of being able to identify what are some possibilities, and where we really need to go to next is actually figuring out how do we do them well, and in which settings do they work well. Because again, primary care is not a monolith, so what works in a federally qualified healthcare center might not work in an academic center or a community center or a system that's not in an integrated healthcare system. So again, we need to be thoughtful about the context.
Well, Dr. Hudson, that's our last question, and we are right at 3 o'clock. And I just want to thank you again for delivering this talk and taking our questions, and for the important work that you're doing. It's really wonderful to hear. So thank you so much.
It's
And
a
thank you
pleasure to be
everyone who
here.
joined. Thank you. Thanks a lot.